Thank you for joining our Debbie's Dream Foundation webinar series. Today's webinar features Dr. Yelena Janjigian. Her presentation will be about major scientific updates from the 2025 ASCO meeting that just took place in Chicago. Before we begin, we'd like to acknowledge our generous sponsors for making today's program possible. Platinum sponsor Astellas, Gold sponsor Merck, Bronze sponsors Arcus Biosciences and Jazz Pharmaceuticals, and Friends of DDF, Bristol Myers Squibb, and Taiho Oncology. First, I'll share information about stomach cancer and Debbie's Dream Foundation. Then, we'll hear a presentation on major updates from the American Society for Clinical Oncology meeting in June 2025. Stomach cancer is the fifth most common type of cancer and the third leading cause of cancer death globally. In 2025, approximately 30,300 Americans will be diagnosed with stomach cancer, and nearly 11,000 will lose their lives to the disease. The overall 5-year relative survival rate is 36%, dropping to just 7% for stage 4, highlighting the urgent need for increased awareness and research. Stomach cancer also disproportionately affects minority populations, with Native American, Black, Asian, Pacific Islander, and Hispanic communities experiencing significantly higher mortality rates compared to white populations. Debbie's Dream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiesdream.org. Pictured here is Debbie Zellman, the founder of Debbie's Dream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors and only vague symptoms. At the time, she was told that her chance of being alive in 5 years was only 4%. Debbie founded DDF in April 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many recurrences. Unfortunately, Debbie passed away on December 23, 2017, at the age of 50, after a 9.5-year battle with stomach cancer. As an organization, DDF continues her important work and legacy. In a few short years, DDF has achieved many great milestones. Our mission ambassadors provide outreach throughout the country. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We also have provided more than $2 million in research grants to date. Patient advocates come together each year at our annual Stomach Cancer Capitol Hill Advocacy Day to secure funding from the Department of Defense's peer-reviewed cancer research program, which allocates funds for stomach cancer research. Earlier this year in March, we traveled to Washington, D.C. with more than 130 advocates and held 180 meetings with lawmakers to inform them that we need more funding for this deadly disease. We're proud to say that this year was our largest turnout yet. We hope you'll join us next year as we let Congress know we need a cure. This is a pre-recorded webinar, but you can type your questions throughout the presentation into the chat section that appears in the webinar menu. This function should be at the top of your screen. Anything sent through the chat feature will be sent as a report to the organizers at the conclusion of this webinar. In addition to the chat feature, you can enter your questions in the Q&A box. It will look like a quote box with a question mark inside. As a pre-recorded webinar, a report from the Q&A section will also be generated to the organizers. All questions asked during this webinar, whether through the chat feature or Q&A feature, will be sent to the speaker, and answers will be sent to the group. Please do not email the speaker directly. Dr. Yelena Janjigian is a pillar in the GI oncology, leading groundbreaking research and pioneering treatment strategies that have transformed the care of esophageal, esophagogastric cancers. Sorry about that. As chief of the gastrointestinal oncology service at Memorial Sloan Kettering Cancer Center, she combines scientific innovation with an unwavering commitment to patient-centered care. Her work, funded by institutions like the NIH and Stand Up to Cancer, has reshaped our understanding of GI malignancies and led to life-changing advancements in treatment. Beyond her prolific research, boasting over 140 publications in top medical journals, Dr. Janjigian is a passionate mentor, shaping the next generation of oncologists. She serves in leadership roles at ASCO, AACR, and Giants of Cancer Care, ensuring that progress in cancer treatment continues to accelerate. Her dedication inspires hope and fuels the mission to improve outcomes for stomach cancer patients worldwide. And at this time, Dr. Janjigian, I'd like to turn the presentation over to you. Thank you.
Thank, thank you. Thanks for the kind introduction and for the opportunity to address this audience because it's so important for me to be able to bring these advances directly to our patients, but also, uh, spread the word and to make sure the clinicians and the community, scientific community, is aware of what we are discovering in gastric cancer. Gastric and esophageal cancer is a relatively rare disease, so many institutions often don't see a great number of these patients, right? So it's important for us experts who solely see this disease. In my typical clinic, I see anywhere from 20 to 30 patients with gastric and esophageal adenocarcinoma, specifically in both early and advanced disease. So it's something that we see often, and it becomes more of a area of expertise to us, maybe not as straightforward to doctors who also see lung, prostate, breast, and gastric cancer. And so doing these webinars is particularly important because by informing the patients, the patient themselves can then make sure that their biomarkers are done properly and also seek out second or third opinions based on the information that they're given from the community, the scientific community. So with that, obviously, ASCO 2025 was huge for our disease. We were featured in the Super Bowl of all presentations, ASCO plenary, which is the biggest meeting, the biggest presentation that happens at the meeting. Just to give you a sense, 40,000 people attend this meeting each year of ASCO, and there's thousands and thousands of abstracts submitted, and out of those, only 4 or 5 abstracts are selected to be presented at ASCO plenary. And gastric cancer abstract, gastric and gastroesophageal junction abstract this year was submitted and was highlighted and with simultaneous publication in one of the biggest journals, scientific journals, New England Journal of Medicine. And this work was to bring immunotherapy to early stage disease. So Matterhorn is a randomized phase 3 study looking at immunotherapy in non-metastatic gastric and gastroesophageal junction adenocarcinoma. And what we need to really know is that the key takeaway from the data we will show you is that the addition of durvalumab to FLOT improved event-free survival in resectable gastric and gastroesophageal adenocarcinoma. 1.2 million people will die of gastric and esophageal cancer in 2025 worldwide. Worldwide, it's a huge disease burden, and in the United States, and particularly in developing countries, there's an increasing in incidence of this disease in patients ages less than 50 years old. FLOT chemotherapy, which consists of fluorouracil, leucovorin, oxaliplatin, and docetaxel, improves survival when combined with surgery for localized gastric and gastroesophageal junction adenocarcinoma. However, despite maximum surgery and this chemotherapy, many still suffer from recurrence. Adding anti-PD-1 therapy, immunotherapy to chemotherapy improves survival in metastatic gastroesophageal junction adenocarcinoma. We already know that immunotherapy works for stage 4 disease. The role of in perioperative setting given before and after surgery, however, remains uncertain. Matterhorn evaluated whether adding durvalumab, which is an anti-PD-L1 antibody made by AstraZeneca, to FLOT improves outcomes in patients with resectable localized gastroesophageal adenocarcinoma. Matterhorn is a large phase 3 study looking at gastric NG junction adenocarcinoma, stage 2 to 4A non-metastatic resectable disease with no evidence of metastasis, no prior therapy, and good functional status patients. This study enrolled globally in 20 countries worldwide, including Asia, Europe, North and South America. Patients were stratified by Asia versus non-Asia location, clinical lymph node status, and PD-L1 expression in their tumor to make sure that the arms are balanced. This is a very well-designed study because it was randomized, double-blind, and placebo-controlled. So the investigators and the patients did not know whether or not the patient was getting immunotherapy or placebo. 948 patients were randomized to receive treatment with chemoimmunotherapy before surgery. Typically, we give 2 cycles of FLOT, which is day 1 and day 15 of FLOT, so 4 treatments before surgery with durvalumab or placebo, followed by surgery, and then 2 additional cycles, so 4 treatments of FLOT, immunotherapy, or placebo, followed by durvalumab or placebo for the rest of the year. So you get 2 months before surgery, 2 months after surgery, and then 10 more months of treatment because the durvalumab is given once a month. The primary endpoint of the study is event-free survival, which is a very good endpoint because you know if the patients had either progression of disease or some other event or death versus, if they're doing okay. Secondary endpoint includes overall survival. So the presentation at ASCO was the final analysis for event-free survival. We also looked at interim analysis for overall survival, and that data still needs to be followed and matured, and the patients are still followed on treatment. We looked at pathologic complete response, and we looked at disease-free survival, which is different than event-free survival because disease-free survival looks at only patients who had complete resection, everything went okay, they were still cured, and then even on top of that, adding immunotherapy after surgery to see how those patients did. The participant disposition means what happened, when we started study versus when we presented the results and did the data log. The rates of treatment and surgery completion were similar between arms. The good news is nearly 100% in both groups completed all cycles of treatment before surgery, meaning that addition of immunotherapy before surgery to standard chemotherapy did not compromise chemotherapy delivery. It didn't compromise surgery because the rate of complete resection in both arms was identical, 92%, which is very good for a trial like this, a global phase 3 study. In fact, most patients, more than 50%, were able to complete up to a year of adjuvant therapy. 52% completed everything adjuvantly, and 68% of patients, so majority of the patients in the durvalumab arm didn't even have an event and are still ongoing in follow-up. The baseline patient characteristics were well matched. You see the range of age that we see with this disease. The median age is 62, but we have patients as young as age 26 and as old as age 84. So we were able to get it into older patients without any problems. It was good functional status patients. Some patients were enrolled in Asia, 19%, but the majority of patients were enrolled in the Western population and South America and North America. Gastroesophageal junction presented 32% of the patients, so the majority of these were gastric cancer, but these were relatively advanced stage tumors. 25% were T4, meaning that it was invading into the serosa, the thickness of the stomach wall, and 69% were node positive. Another interesting point is that most of these cancers, 90% had overexpression of the biomarker that predicts response to therapy, PD-L1 overexpression. So that's good. And what we used, instead of CPS, we used TAP score, which is a new term that's coming out, but it's not that novel. It's the same as CPS, very similar. So when you think TAP, you just think about PD-L1 positivity. And MSI population was very rare, only 5%, which is what you would expect in the study. And these are the curves that we were excited to see at ASCO, and I've presented in many different venues, including this seminar. And there's an early separation in the survival curve. The green curve is where you want to be at. And it's a sustained separation, which means that there's a continuous positive effect to getting immunotherapy. There was a 29% reduction in risk of event, so either progression or death, if you got durvalumab. The hazard ratio is 0.71. Median event-free survival was not reached in the durvalumab group compared to 32.8 months in the placebo group. And the 24 months event-free survival is 67% with durvalumab versus 59% with placebo. And this p-value is statistically significant. So based on this is the reason why the study is getting so much attention, because this is the first study in perioperative setting to demonstrate that any sort of targeted therapy, in this case immunotherapy, can improve outcome over our modern chemotherapy. FLOT is now the standard. We should not be radiating patients. We should be giving them systemic therapy to help improve systemic disease control, meaning reducing risk of cancer recurrence. And above that, we demonstrated that durvalumab can improve survival. And survival curves separate, and there's a sustained separation, meaning that's what the oncologists look for. We don't want the curves to start coming together. They're separated. Looking at this key subgroup analysis, so in the protocol, we always, because we know it's a large patient population, 948 patients, we pre-design it so that we have some degree of granularity as to which patients may not benefit from this therapy and how can we narrow down our scope of the study even more. Well, the good news is that every single cohort, pre-specified cohort on the study, benefited from the treatment. What we look at is we're looking at this dot, which is the point estimate of benefit. And as long as the dot is to the left, which is the durvalumab FLOT, is better, that's where you want to be. And for irrespective of sex, age, even in patients greater than 65, whether or not you're in Asia versus non-Asia, TAP score positivity, even TAP negative patients appear to be benefiting. PD-L1 negative patients appear benefiting, and certainly for gastric versus G junction tumors. So that's a good thing, where everything is to the left of toward the benefit, so that you see a treatment effect with durvalumab. Overall survival, also the curves are starting to separate at 12 months, and there is a separation in the curves. This data still needs to be followed and will be presented at the next meeting in the near future. But so far, we do see appears to be a difference. We just need to follow it, because right now, per the study characterization, this is not a final analysis. It's interim analysis, and we cannot make a determination of whether or not this difference is yet statistically significant. So the hazard ratio is 0.78. The 2-year difference between their survival almost looks identical, right? 76% versus 70%, very similar to what the benefit we saw with in EFS, but that is not yet definitive. What we do know is that the complete response rate, which was centrally confirmed, meaning we look under the microscope and we slice the tumor and we look microscopically, are there any viable cancer cells left? And the pathologic complete response rate is better with durva. 19% complete response with durva plus FLOT versus 7% with FLOT. What this gives us is a hope for possibility of non-operative management in the future, not in the present. In the present, we recommend surgery for all, but if we can figure out which patients are best at moving forward with leaving their organs in place because they had a complete response, that would be a game changer for us. The disease-free survival is also improved in patients who had a complete resection. And this is a common question we ask, our patients ask me, Dr. J, why do I need more treatment? You told me everything was removed. You told me, and the surgeons told me, I had a complete resection and I'm cured. Why do I need more treatment? Well, this is why, because in adjuvant setting, even in patients who had an R0 resection, there's a benefit for disease-free survival in patients who received immunotherapy with chemotherapy compared to chemotherapy alone. 75% 2-year disease-free survival compared to 66%. The hazard ratio is 0.70, so there's a 30% risk reduction for survival, disease-free survival, meaning the cancer is not coming back. So definitely need it if you're fit for it. Let's talk about treatment delivery. So FLOT chemotherapy is associated with side effects of the chemotherapy. What we see is that addition of durvalumab did not compromise delivery of that chemotherapy. The number of cycles across the cohorts is the same, the ability to deliver it. Most patients, as I mentioned, were able to get neoadjuvant number of treatments, right? All the treatments before surgery. And we also know that after surgery, some patients will not be able to complete all cycles, but it's the same number of cycles on average that were able to be completed in both arms. So meaning that durvalumab did not compromise additional chemotherapy. And also the delivery is actually quite good. About 73% of them were able to get everything that they were supposed to get. So, and then 52% of patients completed all year of therapy. So it's better actually than was reported in historical similar trials. There were no new concerns identified with durvalumab or FLOT. We know that FLOT chemotherapy can cause chemo-related side effects, and you see that the FLOT by itself is 59% of grade 3 serious adverse events, 60% with durva. So the durva only really adds minimal toxicity, and these are mostly immune-related side effects, which most doctors already know how to recognize. So the grade 3 for immune-related adverse events were very rare, considerably, but there's 7% in the durvalumab group compared to 4% in the placebo. So the increase was not that high. And there was no compromise related to surgery. The most common side effects are related to chemotherapy. Usually they are low white blood cell count, neutropenia, anemia, alopecia, nausea, diarrhea, and so forth. So those are FLOT-related side effects. We know about them, and we know that we need to mitigate them. So in conclusion, what we saw is for the first time, immunotherapy works in perioperative setting with FLOT. Durvalumab with FLOT significantly improved event-free survival versus FLOT alone in resectable gastric and G-junction adenocarcinoma. EFS benefit was consistent across subgroups and geographic regions. No new safety concerns were identified, and overall survival data is encouraging. Final overall survival will be performed and will be presented. Matterhorn supports global adoption of perioperative durvalumab with FLOT as the new standard for patients with localized gastric and gastroesophageal adenocarcinoma. We call it DFLOT. And this regimen was now published, so you could access this article online in New England Journal of Medicine. It was a big milestone for me personally. It was a big step forward for our disease to be able to present and publish this data at such a high profile, because it helps us as researchers in the field. It draws attention from other researchers, from pharma colleagues, to bring more drugs and resources to this disease. So it's going to really accelerate drug discovery for perioperative setting. This is a patient summary for this. So to be able to look at this data in a patient-friendly format, you can access this QR code. And really, I want to acknowledge the authors and the investigators that made this trial possible, the trial site personnel, members of the independent data monitoring committee. The study was sponsored with AstraZeneca, and it was accruing quickly ahead of the global accrual guideline schedule despite the pandemic. The global pandemic was going on at the time, and it was because of an amazing study team and amazing collaboration of doctors and researchers from all over the world. But most importantly, I want to thank our patients for their caregivers for your trust, strength, love, and the quiet victories along the way. And I had the pleasure to say these words in front of 20,000 people because they really reflect what the study and this effort means to me. Long live all the mountains we moved. I had the time of my life fighting dragons with you, and it really goes a long way to all of my patients and patients worldwide and their caregivers. So thank you, and I'm happy to take any questions.
First of all, thank you so much, Dr. Janjigian. We greatly appreciate you taking the time out of your busy schedule to do this presentation. It means a great deal to our community, so thank you. We did receive some questions ahead of time, so I'd like to ask those in our remaining time. So,
Great.
question number one is this person says, I heard you briefly mention ctDNA recently in Chicago, but I didn't catch it. Can you please share briefly about that again?
Yes, of course. So circulating tumor DNA is a tumor footprint in their blood of the patients. And there's ctDNA research that we're doing to try to figure out, again, when is the patient at the highest risk of cancer recurrence and how we can catch the cancer before it recurs by using circulating tumor DNA as a canary in a coal mine and treating before the cancer shows up radiographically in the metastasis and clearing circulating tumor DNA. So we collected circulating tumor DNA at multiple time points in the Matterhorn, both before the patient started treatment, on treatment, and after surgery, to look at the ctDNA dynamics and also correlate it with patients' immune response to try to understand how can we predict which patients will have the pathologic complete response and maybe in the future tailor their therapy to whether or not they have circulating tumor DNA clearance. At ACR earlier, also in Chicago, so I'm not sure which Chicago meeting they're referring to, but I'll give you a little flavor of this. At ACR earlier this year, in April, I presented data from another plenary, presentation where we showed that if you have persistent ctDNA, your risk of cancer recurrence is pretty much 100% unless you act on it. And treating it early with other treatments, in this case was also immunotherapy for a different study design, helps patients prevent cancer recurrence. And so having circulating tumor DNA investigation from the Matterhorn is very important. With that being said, I don't recommend ctDNA testing routinely on all, especially in adjuvant setting, because, for example, in the Matterhorn, people got immunotherapy. So if you're going to use ctDNA, I think it's it's important to do it carefully, know what you're testing and why you're testing it, because some of the assays are not that reliable. And if you're not doing it in a clinical setting of a clinical trial, it may put you in a situation where the clinical course is not that straightforward.
Thank you for answering that question. The next question was, my husband is stage 4 GEJ adenocarcinoma with METs, a lymph node by kidneys. Would he be a candidate for the Matterhorn study?
I think the question whether or not the tumor is resectable is a very important one, and doing careful staging with laparoscopies and assessment. It sounds like perhaps there's some retroperitoneal lymph node involvement by the kidneys, and those patients technically would not have been eligible for the Matterhorn study because they're considered to be more advanced. And in those cases, I think the decision of what chemotherapy to use, it would be left, important to the disease management team. But immunotherapy is already FDA approved and approved worldwide for that indication. So you could use immunotherapy still, even if, it's not Matterhorn, it's Checkmate 649 or other studies like that that are already proven to us that it's beneficial. And if your doctor prefers to use a 3-drug combination, such as FLOT, again, to maybe tumor shrink and get the patient to resection. Now we have a huge body of literature and evidence to show that they could use FLOT with immunotherapy. So in that sense, that's how I would use Matterhorn data. In medicine, nothing is as straightforward as a phase 3 trial. But that would be the rationale where we know FLOT immunotherapy is safe. And if that's what your doctor thinks is the best approach, it would be, okay to do. And technically, immunotherapy is already an option for stage 4 disease. It's been an option since, we published that data a long while ago, a few years ago.
Thank you. The next question is from a stage 3 patient from Oregon. This person says, what do I do if my doctor will not add durvalumab to my current FLOT treatment?
It's a very tricky question. In short, is that I would advocate and see if you can try to get immunotherapy approved through your insurance, especially if your doctor is aware of the data and is willing to do some paperwork and make some phone calls. It's not straightforward because technically it's not part of the NCCN guidelines yet. Sorry, is not FDA approved, but we are pushing very hard to get this on NCCN guidelines quickly, because obviously we would want to try to get it for patients. I've been trying to get it for patients, and sometimes it's variable because technically the insurance company can just deny it. But I would keep pushing for it. And so far, I have not heard for any patient assistance programs, because sometimes companies do that, but that would be another option if that comes out. But I have not heard of that through for durvalumab. But it's definitely a discussion to have with your doctor.
Thank you. The next question is from a caregiver in Texas. This person says, what are the potential side effects of durvalumab in combination with FLOT chemotherapy, and does my wife need to consider adding on a different medication to combat the effects?
That's a very good question. Immunotherapy is a class of drugs that takes the brakes off the immune system, right? So drugs like durvalumab, nivolumab, pembrolizumab, tislelizumab, we can keep going, but it's the same class of drugs of anti-PD-1 and anti-PD-L1 agents. So theoretically, they can cause side effects by attacking any of the normal organs. And the most common side effects are asymptomatic increase in your liver function tests, so AST, ALT. Your kidney function may go up, so creatinine. Sometimes it's inflammation of your colon or other organs like your lung, although that's a lot less common. The good news is the Matterhorn study showed that the rate of major immune-related side effects is relatively low. It was only 7% compared to 4%. So most side effects come with FLOT. And the other good news is that the doctors actually are getting to be quite good at giving immunotherapy. Even for gastric cancer, immunotherapy has been approved for nearly 4 or 5 years now, maybe more even. And then certainly if your doctor treats lung cancer or melanoma or kidney cancer, they're definitely got the, monitoring of immunotherapy down. So in short, I think most of the side effects come for FLOT. The FLOT side effects are chemo-related, so we usually need to monitor and give people white blood cell shot injections or hydration or anti-nausea medicines. And there's no other special monitoring that you need other than blood tests with immunotherapy. Your doctor should be aware of them. The good news is that Matterhorn showed that we did not compromise the likelihood of complete resection or successful surgery or chemotherapy delivery. So there's, from that perspective, there's less side effects or concerns for side effects.
Thank you. The next question came from a stage 4 patient in Kentucky. She says, I'm currently on FOLFOX and responding well. Will my doctor change my regimen?
If you're on FOLFOX immunotherapy, probably not if you have advanced stage 4 disease. But if you're not getting immunotherapy, then we need to talk about it. But if you're already getting FOLFOX Nivo, you do not need to change to FLOT. No, I would probably wait and do Taxol in second line setting.
Thank you. Another stage 4 patient from London says, I was just diagnosed and I was told I was not a candidate for surgery. What does this new standard mean for me?
This standard is for patients with early stage disease who are eligible for surgery, who did not have access to immunotherapy up to this point. For stage 4 disease that are considered non-medically or surgically resectable, I think this study is less applicable. And there are studies, other studies such as Checkmate 649 or Keynote 811 or Keynote 585 or 859. All of those stage 4 trials are more directed for stage 4 disease. Matterhorn is really for early stage disease. For those patients, there have not been major breakthroughs, and this is the first one to lead the way for immunotherapy in early stage disease.
Thank you. We have a final question. A caregiver in New York says, what is the difference between checkpoint inhibitor immunotherapies like durvalumab and CAR T therapy, and what do you think of the future of cell-based immunotherapies?
It's a great, very sophisticated question, typical New Yorker. So I would say this. Cellular therapy is exciting, and all cellular therapy is taking a subset of a cell that is like a T cell and either taking the patient's own immune system, taking their own T cells, expanding the population and injecting back into the patient, or the new wave of them is cells that are made in the lab or harvested from healthy donors and expanded and then infused back, like so natural killer T cells or other cells. Um, Durvalumab and other anti-PD-1 and PD-L1 agents are completely different. They're biologic agents. They're monoclonal antibodies that are made in the lab in also biologic way from cells that synthesize them. They're actually made from hamster cells that are synthesized in a lab, purified. They're QC'd. They're very carefully sort of standardized. So it's the same antibody that I would be getting as you would be getting. It's not personalized in any way. So in that sense, they're much more readily available. They're off the shelf. We know the side effect profile. You can get them and go home. I don't need to monitor you carefully. I know exactly what's going to happen. So it's a much more off the shelf, accessible product. No matter where you live, you could be living, in Brazil or Cambodia, and you could still get access to those drugs, right? Cellular therapies are a little trickier. Cellular therapies right now are only available in certain centers if you have certain FACT accreditation, and only certain doctors can give them. Like I am a cellular therapist, I can give someone cellular therapy, but most oncologists in the world are not trained to do that. And also, it's because they could be potentially dangerous. So they can have a real cytokine release syndrome. Patients can have really serious side effects. In fact, most of our cellular therapy studies require that you live within a certain radius, within an hour and a half drive from our center, so you can drop everything and come in and get admitted. And some of them, we admit the patients to the hospital. CAR T cell therapies are particularly those, designer T cells that you make in a lab after the patient gets sort of stimulated. We take some of their cells, we expand them and put them back in the patient. They can take 3 months to even get to that point of treatment. And often our gastric cancer patients are too sick to wait that long. And as a result, many of these studies, one of them presented at ASCO actually, this was a randomized study looking with CAR T against Claudin versus standard therapy, just demonstrates very minor benefits measured in weeks in survival. Progression-free survival is very short from these trials. So I think I'm very hopeful that we will come up with some solutions, but they're not as straightforward as some of these other off-the-shelf treatments. And I think for gastric cancer patients, because it's a global disease, patients need to be treated closer to where they live, and also because the patients can progress very quickly, we need to get to them quickly and be able to combine the treatment with chemo. most cellular therapies are not yet prime time for us, but we are working on it.
Well, we appreciate you for working on it, and thank you so much for answering these questions, Dr. Janjigian. Thank you also again for joining us and
Such
sharing
a
your
pleasure. Thank
expertise.
you.
We appreciate it. So, we advise that you please visit the DDF website for some of our upcoming events and programs as listed here. And this concludes today's presentation. Before we conclude, we'd like to thank our generous sponsors once again for making today's program possible. And to view any of our recorded webinars, please visit our lecture library on the DDF website at www.debbiestream.org. That concludes today's presentation, and thank you so much again for tuning in.